Let's jump into the meat of the call for tonight. As per usual, what I will do is start out with some updates on the state of play in the world of international development and how it affects our work to bring about an end to global poverty. As it's January, I'd like to say a little bit about what we're expecting in the coming year. Though, as in recent years, the only thing we can be completely sure of is that there's going to be lots of change and uncertainty. But one thing that we regretfully do have to face up to is that COVID will continue to have a global effect. This is not just something that affects us in our personal lives as we continue to fight against new variants and be concerned about our loved ones and to take personal precautions here in the UK. But also because unless this government gets serious about the global response to ensuring the availability of vaccinations for everyone, wherever in the world they live, we aren't going to see this pandemic under control. At home and abroad, we will continue to see many deaths that could have been prevented. And as we heard last month, advocacy on COVID will also be a big priority for us in this coming year. It is fair to say that the last couple of years have been about the most difficult in memory. Not just because of COVID, but also because of the massive cuts to the UK's official development assistance, or ODA, budget, and the changing priorities of the government. These priorities are increasingly shifting into putting economic development and the UK's national interest ahead of poverty reduction and ahead of focusing on the needs of people living in poverty. Now, while we've been given a timetable for when we expect the ODA budget to return to 0.7% of gross national income, we're still going to see a net reduction of funds for development programs over several years. The damage that this has done has partly already been done and partly has yet to work through the system. The results of that? People fail to have access to healthcare or nutritious diets, or are unable to get an education, or can't earn a living or look after their families because they can't get medical treatment. The consequences of this are profound. I always make a point of saying that the numbers we talk about, millions or billions of pounds, all these figures with lots of zeros in them that are really hard to understand in human terms, they are important because they translate directly into lives lost or blighted unnecessarily. This affects real people right around the world, and that's why all of us in this call can get involved, and why we all want to learn what we can to do to improve the situation. It's why, as I said last month, the ODA cuts are going to continue to be our focus at results. At some point in the first part of this year, we're told in the spring, we expect the government to publish a new international development strategy. And given the public statements made recently by both the current Foreign Secretary, Liz Truss, and her predecessor, Dominic Raab, we can make some very good, educated guesses about what's going to be in it. We expect to see more development funds, which by law must be spent on poverty reduction, instead be distributed via economic instruments and loans rather than grants that get spent directly on programs that meet the needs of people living in poverty. And this newly prioritized spending is often among the least transparent parts of the government's ODA spending, with a very poor track record of poverty reduction. What we're seeing are increasingly incoherent policies from the government, making it hard to see how they'll achieve their stated ambitions. On the 14th of December, the FCDO, that's the Foreign, Commonwealth and Development Office that spends the bulk of our aid money, released two important policy papers, one committing to end preventable deaths of mothers, babies and children, and one to health system strengthening. We're going to drop both of those into the chat box in just a minute. But now, both of these are uncontroversially excellent things to aim for, but without the resources to achieve them, they simply can't be delivered, and these documents will not be worth the paper they're written on. For example, the Foreign Secretary and the Prime Minister have both recently stated that women and girls are at the centre of their priorities. Yet without committing money to nutrition programs, as it failed to do at the Nutrition for Growth Summit in early December, and without adequately funding girls' education, as it failed to do back in July, this aspiration is hollow. Yet the foundational importance of nutrition and education are acknowledged multiple times in the government's own documents. This just makes no sense. Again, this is something that results campaigners will almost certainly need to make a noise about at the appropriate opportunity as they arise during the year. I also want to briefly mention tuberculosis, which last month we heard is a priority for us in 2022, given the huge damage done to TB and other infectious disease programs by COVID. We expect the Global Fund to fight AIDS, TB, and malaria, the biggest agency fighting those three diseases, to need to be replenished by international donors to the tune of many billions of dollars later this year. And if it is to do its job in ending the three epidemics, and if it is to do so in the face of the massively increased levels of disease because of COVID, that replenishment figure could be over $20 billion. We don't have any updates on the timetable for this since last month and are still expecting the replenishment itself to happen in the autumn, with the conference to be hosted by the US government. The Global Fund will release its own case for investment in the spring, which makes this year's World TB Day on the 24th of March an especially important one. Rest assured, we will be asking you to take action on this, though we aren't quite ready to raise the issue this month. We need to find out what needs the Global Fund itself is identified first, as it'll say when it launches its investment case. So now, before we hear about the subject of this month's advocacy, which is the fight against another debilitating disease, polio, it's time to hear updates about your actions around the UK over the last month. So I'm going to hand over to Ruthie for the Grassroots update.
Thanks, Aaron, and Happy New Year to everyone, and welcome Tanya, Emily, and anyone else who's joined us for the first time. So in this roundup, I've got quite a few additional activities, opportunities, and actions that you could take and get involved with. So I just want to start by reminding everyone that as much as we encourage you to get involved with different and additional things that results, we appreciate you only have a limited amount of time. So please just do what feels manageable and interesting and enjoyable. It's all optional, of course. So to cast our minds back to December, the action was to reflect on your campaigning in 2021 and to look ahead to this year. So we hope you found that a useful action and took the time to take a step back. It's always a valuable thing to do to strengthen our campaigning and what we're doing. So if you didn't manage it in December, I'd encourage you to make the time to reflect and plan on another occasion, maybe as part of your January meetings or later on this year. And as Aaron said, in December, there was the Nutrition for Growth Summit and also the publication of 2 important strategy papers. And following the summit on nutrition, a few of you have started to receive replies back from the FCTO, the Foreign, Commonwealth and Development Office. And you were writing to call for funding and policy changes to tackle malnutrition. And the replies that we've seen coming back state that the UK is committed to tackling famine and that the use of the policy marker for nutrition will now be implemented, which is a big win and means that it'll be easier to track the UK's action on nutrition. But the letter mentions the importance of nutrition in achieving the ending preventable death strategy. So whilst there are positives there with the strategy and the policy marker, the letters do also say that, let me just get the wording right, nutrition funding is yet to be determined following the October 2021 spending review. So we think there's still an opportunity to push for this nutrition funding that we didn't see happen and committed at the Nutrition for Growth Summit. So if you didn't take the November action, or you're keen to follow up with your MP or Liz Truss on nutrition funding, then it's not too late, is what we think. And if you're interested in reading a summary of what happened last year in terms of global efforts to tackle malnutrition and what we're advocating for the UK to do and hoping to see this year, we've got a new blog out that kind of summarises everything. So we'll put that in the chat, and also we'll put in the link to the November action if you are interested in taking an additional nutrition action in the next, we think maybe there's a month or so. So again, we're working to short timescales with quite a lot of these issues and funding asks. So your campaigning on nutrition and all our campaigns last year was incredible. So I just want to remind you about the 2021 Grassroots Scrapbook we put together to thank you for everything you've done and celebrate highlights from the year. So if you haven't seen it already, please take a look, and that's also in the chat box. Now, a big project that the Grassroots team is working on at the moment is a review of how we can best support you and where and how we could improve our public campaigning. So the next and important step in the review is hearing from you and people across the Grassroots network. So your views and input will be invaluable, really, and would be really grateful if you could get involved somehow. So there's two ways you can feed into this review and share your thoughts, experiences, and ideas with us. Firstly, we've got a survey, which will approximately take 10 to 15 minutes to complete. So we'll put the link in the chat. I think we're keeping that open for a few more weeks. But yeah, if you could fill that out, that would be brilliant. And if you're up for a bit more of an in-depth discussion and chance to chat in small groups with other volunteers, staff, and trustees of results, then we're holding 2 focus groups and would love for you to come along to one of them. So the focus groups will take place on Zoom on Thursday, the 20th of January, 3 till 4:30, and Tuesday, 25th of January, 6 till 7:30. So if you are interested in attending one of those, please email Naveed and we'll make sure that you get the details. And just thanks to those who have already filled out the survey and signed up to come along to a focus group as well. And they're open to everyone, so no matter how involved you are with results, if this is your first call or 200th call, then we'd still love to hear from you. A couple of last things on COVID advocacy. So in our recent emails, we've mentioned the opportunity to attend a lobby day organised by our friends at One, but they've postponed that. So the original date was January the 18th, and it's now going to be on February the 22nd. So if you are interested and haven't told us already, please email us, and again, we'll be in touch with more details closer to the time. And another thing mentioned in this month's action materials and our email was that there's an advocacy opportunity this week, in fact, related to COVID-19 vaccines and routine immunisations and health system strengthening more generally. So this Thursday, there's a parliamentary debate on how do we ensure equitable access to vaccines. So if you have engaged with your MP on this issue before, or you know that they're interested or supportive generally of issues related to vaccines and global health, then please give them a call and ask them to attend the debate. It is quite a last minute action and will probably need to be taken tomorrow, but I thought I'd mention it anyway, and we'll put a document in the chat that's got the information you need if you are interested and able to do that. And as you'll hear on tonight's call, support for access to polio vaccines is vital in the fight to end polio and in health system strengthening across the world. So yeah, the debate's closely linked with this January action. So yeah, let's get on to that topic now. Back to you, Aaron.
Thanks, Ruthie. That's great. And that's one of my favorite parts of the call. Let's jump onto the topic of tonight's call, which, as Ruthie mentioned, is the eradication of polio, a debilitating childhood disease that's been with us throughout human history, but which stands a good chance of being only the second disease ever to be completely eradicated from the world. To tell us why this matters, we've got a great expert speaker this evening who I see is with us, which is great. I'm going to introduce her in just a second. But before I do, I just want to give a bit of context about the UK's cuts to ODA that I mentioned earlier. We know that with the cuts to the UK's ODA budget, there's not enough money to do everything we'd like to do in the fight against poverty. Not all the things we work on will be fully funded by the UK government this year, sadly, as we saw in the case of education and nutrition last year. But the resourcing for polio is amongst the most at risk, partly because of the scale of the cuts to the polio programs that we saw in 2021, which was around 95% cut, and partly because we don't think this is yet on the Secretary of State's radar whatsoever, and it really needs to be. So thank you for anything you can do, including if you're able to get your MP along to the immunisation debate in Parliament on Thursday that Ruthie just mentioned. Polio is definitely going to get mentioned there. So now I'm going to introduce our guest speaker, Sona Bari, who's the External Relations Coordinator for Polio Eradication at the World Health Organization. And she's joining us this evening from Geneva, which is an hour ahead of us in the UK, so it's a little bit late for her. Sona, welcome.
Hello, I hope everyone can hear me okay.
You're coming through loud and clear. Thank you so much for joining us tonight. Let me start by letting you know who we've got on this call. You're joining our grassroots volunteer campaigners from right across the UK, from Scotland to the South Coast, people who regularly take advocacy actions, mostly aimed at the UK government, to try and persuade them and convince them and force them to meet their international development obligations and fund the kind of programs that make the most difference to people living with poverty and injustice. We've got people on the call who've been working on these issues for many years, but we've also got people joining us tonight who are really new to international development and global health and who won't know much about polio at all. So we've got 3 pre-prepared questions for you, but before we ask those, I'm going to ask what I ask our guest speaker every month, which is, can you explain briefly what got you into your area of work? And what is it about your work at the WHO that fires you up and makes you want to come into work every morning?
First of all, I'm really honored to join everybody because polio eradication is an effort that has actually succeeded so far because of people like you. It is entirely because of grassroots advocates that this program has gotten to where we are. So it's really an honor to be addressing everyone across the UK tonight. I came to polio eradication as someone who started out as a journalist and covered many issues, one of which was humanitarian disasters and conflict, and then wanted to be more than a journalist. I wanted to be an activist. So I entered sort of the field of human rights. And when I saw this job in polio eradication almost 20 years ago, I applied for it knowing nothing about public health, but what drives me is that this is something that we can actually do. It's a very concrete goal, and it's all about equity, which is what moved me from journalism into activism in the first place, was about equity of access and equity of services. So that's why I do what I do. And external relations in WHO is really essentially, in such a scientific organization, you need people who can take the science, explain it, and advocate for it and say, this is the problem, this is how we can solve it, this is the help we need from you. So that's essentially my job.
Thank you so much. I love hearing that story. Everybody has a different way, a different pathway through to this work against global injustice, and it's really great to hear yours. So let's jump into the first of our pre-arranged questions before we open up the floor to general questions. When we do that, for anybody that would prefer to text in a question, maybe you're not near the keyboard or you'd prefer to do that, the number to text questions into tonight is 0777 56 11178. That's 0777 56 11178. And I will admit that the last time I did that, somebody texted in a question, I missed it. So apologies to whoever that was. I will not miss it this time around. But we are going to go to the first question this evening, which should be from the Manchester group.
Hiya, can you hear me okay? Cool. I'm Rachel, I'm from the Manchester group. And my question is, why is supporting the Global Polio Eradication Initiative so important if polio is 99% eradicated?
First of all, it's a highly infectious disease. And now in the day and age of coronavirus, you all know what that means. When polio existed everywhere, a child could go to school in the morning and by the afternoon be paralyzed for life. People lived in fear, much as we do in many parts of the world with COVID. So when a vaccine was developed, it made global headlines, much as the COVID vaccine did. So fast forward 30 years, almost every country has vaccinated its children, meaning the virus has nowhere to circulate. However, 2 countries remain, Afghanistan and Pakistan. And meaning that the virus can circulate in those places and it can leave those places and it can find children who are not vaccinated enough or who are not vaccinated at all. So why do we have to cover that? Because the first reason is scientific. In eradication, when you set out to completely wipe a disease from the earth, the only number that counts is 0. It doesn't matter that 2 countries are left or 5 children were paralyzed, down from 1,000 children every day, 5 children in all of 2021. The only number that matters is 0. And since polio is so infectious, it's what we call an epidemic-prone disease. Once it does get into, say, Switzerland, it has pretty low vaccination rates, actually. If poliovirus arrives in Switzerland, it could find what we call a susceptible population, and it could surge back. And we know that given the current rates of immunization in the world, within 10 years, we would say about 100,000 children paralyzed every year. So it's not a disease you can contain. And as to use a phrase that we've all heard during this pandemic, no one is safe until everyone is safe. But that leads me sort of to the second reason as to why we should still care about it, which is an ethical reason. We've had a safe, effective vaccine for 50 years, over 50 years. We have a moral obligation to ensure that everyone has access to that vaccine. And to do that, we need to know where the disease is. So we have to have surveillance, which we carry out right now in 70 countries. And you have to offer protection against it through a strong immunization system or through vaccination campaigns. So until we finish the job, we have to keep paying attention to it.
Thanks, Sona. Really great answer. Powerful message there. The only number that matters is 0. Let's jump across to our second question, which is coming from Oxford tonight. Great. Tiffany's put the question in the chat. Very resourceful. I will go ahead and read that out if that's okay, Tiffany. Tiffany from Oxford asks, our question is, how have polio workers been affected by the COVID pandemic?
Oh, like all of us, they've been affected as individuals, communities, parents, and many of the polio workers are in countries which have borne the greatest burden in terms of disruption to their health services. So it's been very difficult to the more than 30,000 people who work on polio eradication worldwide. So like every aspect of life, immunization was affected when COVID-19 hit. Parents couldn't bring their children to health facilities, or outreach workers couldn't visit homes. Our lives were so much more circumscribed. And so millions of children couldn't be vaccinated. We estimate about 80 million children missed their vaccination, not just for polio, but for routine childhood immunization overall. This built up what my scientific colleagues call an immunity gap, which means that if we had been able to vaccinate, those children would have been immunized, but they are not. So there's a gap in the wall of immunity. And that's really what prevents polio or any virus from going through, right? You build a wall so that the virus can't break through. But we now have a gap. So what did polio workers do? Well, in this pause, when we couldn't vaccinate for anything else, we basically all pivoted to supporting COVID-19 response. Because of the way that polio eradication works, we have workers at the forefront. These are the people going door to door, checking on whether there is polio and vaccinating children. So they were doing contact tracing, they were doing surveillance for the disease. They help engage and educate communities on hygiene and physical distancing measures that needed to be in place. Our lab network, which is 146 labs worldwide, did the testing, the data analysis, a lot of the genetic sequencing that you hear about in terms of COVID variants is done by polio labs. And polio workers know how to manage a vaccination campaign, which is it's a huge operational challenge. So from cold storage, some of these vaccines in COVID, as you know, need to be kept very, very cold. From cold storage to how to vaccinate, to operations, how do you make sure that everyone in a particular catchment area is covered? They are now helping with the vaccine rollout. One of the interesting stories I heard recently is in Afghanistan, when the government fell apart and was subsumed with the new Taliban administration, people had to go around figuring out which health centers are still operational. And that was polio workers who did that, who went to each health center to see, is it still standing? Is there a fridge? Is there electricity? Do we have needles? Are people coming? Or has it been bombed out? All of those things had to be recorded so they could go ahead with COVID vaccine rollout. So that's the sort of thing that polio workers have been doing.
Wow, incredibly powerful, and a lot to get caught up on by the sounds of things in terms of, so I think it's one of the only times I've heard building a wall being a positive thing and recently. So yeah, let's jump over to Linlithgow for our third question.
Hi there, Bentley from Linlithgow. how does polio program contribute to strengthening health systems generally in these countries? Right.
Isn't health system such an unappealing term to get your head around, right? It's just, you wish that there was a better way to put it, and yet it's something that we interact with daily, right? So one of my favorite experiences in polio eradication is in the eastern part of India, in a state named Bihar, which was one of the last states that eradicated polio in India. It has, it's a very poor state. It has very poor health systems. So there was a part of this state called the Kosi River Valley, where there were no health facilities. People weren't getting any kind of services from the government, because what this river did is in the monsoon, it would flood, and then when it went down, it would leave behind very fertile sandbanks, which people would move into for about 8 months of the year and farm intensively. But these were largely, you know, landless people. The government didn't even really know where they were or whether they existed. So when we tried to eradicate polio here, this is a place where no service goes. There's no schools, there's no roads. You know, these are people who survive really at the sort of, it's a very basic level of survival. They don't really get any services from the government. And when we started going there, our workers would have to stay overnight. They would just camp out there because there wasn't any place to stay. And the community would say to the workers, you polio people, you go to places where even the rays of the sun don't penetrate. And in a way, that summed up for me what the Polio Eradication Initiative does in terms of strengthening health systems. And it sort of goes back to our roots. When Rotary International launched this effort, they called it Polio Plus, because what the workers in these areas do where there are no services is they monitor for other diseases, they advise mothers on breastfeeding, they weigh newborns, they register newborns. In many places, this was completely a new thing that we were able to register newborns. The government had never been able to do it. They give other medical care. They also, of course, provide other vaccines sometimes, depending on the age range. And the reason we're able to do this and sort of as an input into health, a stronger health system, is that polio eradication has a sort of unique set of experiences. And it's all about, again, because of that immunity wall, because the weakest link or the chink in the wall is where the virus can get through, polio is very focused on that chink. It's focused on that weakest link and finding where are the people who are not served. So let's go plug that hole there to make sure that the virus can't get through. And one of the things I think that we do in health system strengthening is not just the input, because of course that's, you know, many other health interventions do that, but it's also the infrastructure of how do you do that? How do you find the underserved and figure out a way to serve them? And that has been beneficial to a host of health issues. And it's really fundamental to strong primary health care and to eventually the WHO's goal, universal health coverage. I hope that wasn't too policy wonky an answer. Tried to be as concrete as I could.
Thanks, Ed. Thank you.
I certainly don't think so. I think that what you're getting at there is the true equity related to that, right? The polio virus doesn't really care about your statistics. You need to get every single child. It's the ultimate test in a way of whether you're really delivering equitably across the whole population. Incredibly powerful. Sona, thank you so much for those questions. We're now going to open up the floor. I think we had a couple of questions. We had one question in the chat. Feel free to put more questions in the chat as we go. The number again for people that want to text in a question is 0777 56 11178. I know that some of you on the call have been campaigning on polio for many years, and for some, this is a new issue. So please do ask your questions, whatever they are, either basic or complex. No question is wrong. And it's probably fair to say that disease is probably no longer understood by the public nearly as well as it should be, not the least because of our successes as a global community at almost eradicating it from the planet. So do go ahead and introduce yourself before you ask your question. Does anybody want to ask a verbal question before we go to the chat? I see a hand going up. Pete? I think you might need to unmute yourself.
Okay.
There we go.
Yeah, hi, this is Pete from the Poole and Bournemouth group, the South Coast. Just wanted to ask, you can understand how in Afghanistan, vaccine delivery is going to be a problem. But in Pakistan, what's the problem there? Is there vaccine refusal, vaccine denial?
Would you like me to already respond, Aaron?
Please.
Yeah, please go ahead. Yeah.
Okay, yeah. Hi, Pete. In Pakistan, on a national level, vaccine acceptance is actually higher than most of Western Europe. So that's not really the issue. There are pockets, definitely. So I'll maybe start with the sort of minority issue and then come to what is really the bigger issue. The smaller issue that, as in many countries, you have communities that don't get services from their government or who are mistrustful of the government for whatever reason. And these are communities that tend to say, well, we're not getting education or social security or electricity. Why are you coming with these free polio drops? There must be something in it for you. And, you know, we don't trust you, you're outsiders, or we don't trust the government for whatever reason. We see that in the United States, where I come from, quite a lot in minority communities. And with COVID, we're seeing it. And I think there's some of that in Britain as well. So there are communities where that is definitely a challenge. This is particularly among a language group, people who speak Pashtun, who are from certain communities in what is sort of the northwest of Pakistan and southern Afghanistan. That is a community that has much higher rate of polio cases and much lower vaccine acceptance. That said, at the national level, largely the issue is Pakistan has not succeeded in reaching the most vulnerable with its vaccines. And why are we not doing well in Pakistan? We haven't really yet, and this year in 2021, it actually turned around a lot. We haven't succeeded in delivering our operations properly. So when we're going to a block of houses, are we really following up? Is our operational excellence at a level where it needs to be? And in Pakistan, it simply hasn't been. So it's really about tightening up in those last areas where we're not reaching the kids we need to reach. We need to be better at the operations, and we do need to be better in some communities with addressing their concerns about vaccine. Does that answer your question, Pete?
I think it does. I didn't see, I was changing screens. So if you know, thumbs up, great, excellent. We've got another hand up. So before we go right into the chat for some of the ones there, I'm going to go to Kathy. Kathy, do you want to go ahead? And just for other folks, if you hit the reactions button at the bottom of the screen, there is a raise hand function there. So you don't have to wave actually furiously in real life and hope that I spot you if you want to use that facility.
Thank you for coming to me. And thank you so much, Sona. It's been a really interesting and exciting update on what we've learned about polio, which I think is a really important program. And it's really sort of gets to why aid is necessary. But I just really wanted to know whether WHO has already begun to fear or identify, has COVID actually had the impact of increasing numbers of polio infection rates at all? Or is that still a future issue that will be coming down the line?
It's sort of both things. In one way, the physical distancing and the fact that people have been unable to travel has led to a drop in transmission. So it's sort of a little bit of a silver lining or a blessing in disguise. We are seeing less transmission. But the reason that my colleagues are not complacent, and in fact quite concerned, is that we now have a cohort of children who we could not vaccinate during these restrictions. And we are concerned that we will start seeing, as people start traveling, we will start transmission going up, and the virus will find these children who are in that immunity gap that I was talking about. So although right now we are at very, very low levels, in 2021, we had 5 children paralyzed by polio in Afghanistan and Pakistan. We're still not, 5 is still too many in eradication. And so it's kind of both. Yeah, COVID in a way has helped by curtailing people's movement. But in the other sense, it's prevented us from protecting people.
Massive increases in vulnerability exist, is what I heard you say there, Sona. Mm-hmm. And that makes the UK's returning to the table as a major donor would be the time to do that is right now. Really, really clear. We are going to go to some questions in the chat, and we'll start at the top. You may not know the question to this one because it's a technical one with a very specific answer, but Peter Lima asked, how much more transmissible than COVID is polio?
That is a very scientific question. Polio, so because COVID is essentially through droplets and airborne, it is much more transmissible. So if we were all sitting in a room and one of us was positive, pretty sure that in a period of time we would. Polio is a little bit harder in the sense that it's an oral fecal route, which is why children tend to get it, because as any of us with children know, we're very dirty creatures when we're little, and there's a lot of, butt to mouth action going on among children. So it's just a different mode of transmission. So I would say it's not more or less transmissible. If you have a bunch of 2-year-olds together, they're definitely going to transmit polio to each other.
Right. Absolutely.
Thank you.
Let's go to Harriet Stewart Jones. Hopefully a slightly less scientific question. Is the vaccine still delivered on a sugar cube?
No, I wish it was, because that's how I got it. But these poor kids, we just pinch their cheeks and we put in 2 drops, and it's bitter, it's disgusting. None of that sugar, because of course the WHO can't hand out sugar.
Right. Yeah, we tax it in this country. And Stephen, your questions, you've written quite a long question there. I don't know if you actually want to speak that one out loud.
I think we missed Tiffany's question, didn't we? I want to jump the queue. How are polio workers ineffective? No, wait, we asked that before. Sorry.
We asked that one already. Yeah. Please,
yes.
please.
Okay. I was looking through them and I got mixed up. So I'll just read it out loud then. So we all know how dire the situation in Afghanistan is right now. We've heard how polio eradication can help promote health systems more generally. I'm interested to know about the other direction of causation. How much other programs aimed at improving health and development can link into the polio efforts? And I've kind of put on the end there, I'm not sure quite how relevant this is, but I'm interested to know anyway. Should we support placing tight conditions on aid to Afghanistan, even if this means less money getting through?
Oh, so the first part of your question is easier for me with my knowledge base to answer. Absolutely. One of the things we're doing now as part of our new strategy, which we developed last year, and from 2022 to 2026, we have a new strategy. what we were doing before in a sort of ad hoc and patchwork way was working more with particularly the water and sanitation sector and the education sector, to a certain extent the road transport sector because of people on the move. If we have better sanitation, definitely it will be easier to eradicate polio. Now, as WHO, we are a very medically driven organization. So our answer to everything is there's a vaccine, there's a medical intervention, we can prevent, we'll cut down on doing this health behavior or increase that health behavior. So we look very much through the lens of health. But we are now trying in our new strategy to work more systematic, to go from the ad hoc approach to work more systematically beyond the health sector, to work with water and sanitation, to work better with the transportation sector. And these are things, this sort of integrated approach that is really necessary in what we think are the last steps towards zero. So your question is really pertinent and really timely. And it's one that we actually hear from the UK government and other donors a lot. We're contributing to water and sanitation. Can you guys link up better? And that's what we are doing starting this year in a much more sustained way. The second part of your question in terms of development aid, I'm not really qualified. I'm not an aid expert in that sense. I do know that one of the best things about the UK's aid so far has been that it's very unearmarked. So it's the UK will say to the WHO, use this where you think, as the technical experts, it's going to be most effective. Whereas a lot of donors will say, we want you to use this for children age 3 to 5 in this geographical area, because there are other things behind the aid, right? Of course, every government has its own reasons and motivations. So, we want you, Turkey might say, we want you to use it only for Somalia, and Germany might say, we want you to use it only for Syria, for example. The UK has been a very good partner in that sense, in that as a member state of the World Health Organization, it says to the World Health Organization, we have mandated you to know the best scientifically how to do this. We're going to give you this money, you decide what's the most effective way to spend it. This is one of the reasons, and I don't want to speak for your government, but this is one of the reasons why governments give to the WHO rather than to another government, because putting those conditions on a fellow member state is politically challenging. So that's one of the roles that the WHO serves.
I think that's really important, Sona. I mean, that ability to be driven by the science, to borrow a phrase, is really, really, really important. And I think, as we're going back to our government and saying, we want you to come back to the table on polio, the fact that those contributions have historically not been tied to specific countries or specific outcomes or specific ways of tackling the problem, but have been left to the technical experts to deliver, is what made the UK contribution so exceptionally valuable. And we want to preserve that as part of the ask. It's really, really important. There are two questions in the chat. The first one from Carolina, which is quite a technical question. She clearly knows her stuff around polio, given that question. Carolina, do you want to jump on and actually ask that question out loud? Maybe put a bit of, maybe expand on it a bit for people that maybe don't have the same level of technical knowledge that you have. I think it's a really interesting thing to be grappling with.
Well, I wouldn't say that I'm expert in that area. I just work in the science. So I'm just curious about this, because we know this 3 letters is mean how we giving the vaccine. So the first one is the oral, as we spoke, and second one is telling us about that is part of virus which is inactive, which is supposed to be more how to say, working better. And that's why I'm wondering if it's possible to switch in to the better vaccine, even if it's more difficult to provide for many people in difficult areas.
And Shannon, before you answer, I noticed that Jill has also asked in the chat, what is vaccine-derived polio, which I think is probably going to be part of your answer, but just drawing your attention to that one as well.
Yeah.
Please go ahead.
So Carolina, you're absolutely right. One is the oral polio vaccine, which is a weakened form of the virus. And the other is called inactivated polio vaccine, which is a killed form of the virus. Oral polio vaccine has certain advantages, and inactivated polio vaccine has certain advantages. Both were developed pretty much simultaneously. Inactivated poliovirus was developed first. The advantages of oral polio vaccine is that for most countries, it is really the only vaccine they can deliver. It's not only the cost of the vaccine, it's inactivated polio vaccine is at least 5 times as expensive. But it's also the fact that you need a trained health worker to administer an injection, which most of these countries do not have enough of their trained health workers. Whereas for oral polio vaccine, anybody can administer it with minimum training. The other advantage of oral polio vaccine is that when I take oral polio vaccine, I'm shedding it in my stool. And in a situation where there is low sanitation and people are infecting each other, or children rather are infecting each other, I am passively sharing that immunity. So it's creating herd immunity. When I take IPV, inactivated polio vaccine, I am only protecting myself. There is no community benefit to it. So in every country except for Finland and I think France, oral polio vaccine is a vaccine that stopped community transmission. So in terms of eradication, it is the only vaccine that can stop the virus spreading in a community. IPV will only stop the virus in you, in one individual. Once most countries in the industrialized, wealthier world had stopped polio transmission, only then did they consider switching to IPV. So for example, my daughter was born in the year 2000. The United States had its last case of polio in the late 70s. But the United States continued using OPV until the year my daughter was born. She was the first cohort to have IPV only, because it was considered that the benefits outweighed the risks. Now, the risks of OPV, of oral polio vaccine, however, because it is a live vaccine, when I take it, if I am in a community that is very poorly vaccinated, let's take Somalia, parts of Syria, many parts of northern Nigeria, where there is not that strong immunity wall, that weakened virus will find another child. It won't paralyze that child, but it will continue transmitting because it will be able to find. And every time it changes, every time it's passing from me to another kid, it regains strength, and it can ultimately start paralyzing children. It's what my scientific colleagues call reverting to paralytic form. That is what vaccine-derived poliovirus is. And we now have many more cases of that than we do of wild poliovirus, because we have been able to shut down wild poliovirus largely. So we knew that this would happen. So one of the things, to come back to Carolina's question, is most countries are not ready to use IPV because they simply won't be able to deploy it. But we have now developed something called novel oral polio vaccine, which is not reverting to that paralytic form anymore. So I'm not a scientist. I hope I was able to explain that coherently.
Yes, thank you so much. Yeah, I know that it's very difficult to provide any help in poor countries, and this way I'm sure we will find the way with that virus as well. Very good.
Thanks for the question. And Shona, I've heard that explained probably over a dozen times, and that was one of the best explanations I think I've ever heard in 5 minutes or less. Thank you so much for that. We have only 4 minutes left. Double checking on the phones. I don't think I can't see a texted in question, so we probably have time for one very final question if somebody wants to raise their hand. We can squeeze one more in if it's short.
Aaron, I just got a very quick question. Hi there. Just for interest, kind of a follow-up to Carolina's question. Does the polio virus change? Does it mutate, or is it just stays the same kind of constant, the same type of virus over decades? If you could
polio
explain.
virus, it does mutate. Any scientists on the call will be able to say this better than me, but my understanding is that all viruses mutate. So if I'm infected with the polio virus, it will mutate in my gut, in my intestines, and then when it passes to you, it will mutate in you. One of the ways in which we see whether virus is spreading is similar to COVID. We do genetic sequencing. So we know, for example, now that all the wild polio virus in the world is in Pakistan and Afghanistan, and they're all related to each other because we can genetically sequence them as they mutate from person to person. But they don't mutate into another virus. No, it's not like coronavirus.
So does the vaccine have to change slightly, or can it remain the same generally? Or
so the vaccine, in oral polio vaccine, the virus is a weakened form of the poliovirus, and it will mutate, yes. And if it finds other people to infect, that's when it will start mutating back to its stronger, more paralytic form. But if it doesn't find other people, then it won't.
Does that mean you have to change the vaccine itself, or can the vaccine stay the same?
No, it's not like the cold. It's not like the cold influenza vaccine. No, we don't have to.
Okay.
Yeah.
Okay. Cheers. Thank you.
Great. Good to hear. I am really afraid that we are have run out of time. So I think it's time for me to start wrapping everything up. I think big thank you, first of all, to everybody on the call for your questions. I think they were great questions. And I do want to, of course, say a massive thank you to you, Shona, for joining us this evening. It is getting late, very late for you by now, but incredibly articulate, incredibly compelling case for that one last push on polio. There is a special role the UK can play, as we've heard, and the way that it gives us money and the level that it was giving at is really important to brick up the holes that we have in the immunity wall, and particularly given the vulnerabilities that now exist because of the COVID interruption to treatment. Very, very, very helpful. So thank you so much.
Thank you. It has been an honor speaking to you. Anytime, happy to come back and meet you all.
Well, hopefully one day we'll be able to do that face to face. We are crossing our fingers that our national conference will be able to be face to face this year after too many years of not being able to see each other. So you never know. That would be lovely. I really just want to finalize the call by saying a big thank you to everyone for everything you're doing around your advocacy, all the different asks you're making of government. Now is really the time to be putting this ask in, particularly on polio. It's so very important given the way that budgetary decisions are being taken in a very, very tight, constrained funding environment in 2022. Let's get this on Liz Truss's radar. It's time for us to say good night, goodbye from me. I look forward to seeing you again at the next Grassroots Conference call. That's going to be on Tuesday, the 1st of February. So after a big long gap between the first Tuesday in December and the second Tuesday in January, so you all could have a good recovery from your New Year's Eve, it's not going to be very long at all before we're on Tuesday, the 1st of February. So looking forward to seeing you again very soon. Enjoy the rest of your evenings. Take care. Bye now.